You're tuning into the Active Mom Podcast with physical therapist Dr. Carrie Pagliano, a real mom's guide to all things postpartum return to workouts after baby. If you're a postpartum mom, coach, trainer, or physical therapist looking for answers on how to get back to running, CrossFit, yoga, Pilates, HIIT, you name it, without the fear of pelvic floor issues or doing something wrong, this is the podcast for you. Let's start the show. All right, super special guest on the Active Mom Postpartum podcast today. We have my hip surgeon from 16 years ago. I know it's like a whole other lifetime. Dr. Derek Ochiai is at Nirschl Orthopedics in Arlington, Virginia. We have known each other a very, very long time. And I want to talk hips and pelvic floors and all that fun stuff, because as you and I both know, there is a boatload of crossover. So when did you first get kind of, I don't know, turned on to the idea that there could be stuff going on, because you've done hips, gosh, how long now?
Yeah, I did my first hip arthroscopy. I think it was 2003 is when I
Yep.
did my first one, and then became really a major part of my practice in like 2006-ish.
Yeah.
I so I really didn't think that pelvic floor issues and hips. I looked at them like a Venn diagram where like there's one big circle over on the one side and there's
Yep.
one circle on the other side, and they're just like a bunch of space between them.
Yep.
Um, so then I got a referral. I think I was looking back in my notes. I think it was like 2009,
Hmm.
where I got a referral from somebody who I later found out is like a well-known pelvic floor surgeon,
Oh.
that sent a patient over to me that uh, had vulvodynia, and
Oh, yeah. This is all kind of vaguely familiar, and I'm remembering now, like, because I think we were starting to get some crossover and people connecting
yeah,
between the pelvic floor surgeons and you. Yeah.
right. So he had gone ahead and gotten an MRI of this patient's hip, and
Hmm.
they had a labral tear in their hip, and so they were sent over to me, and they had a bunch of very, I mean, I think I'm not a pelvic floor doctor, a bunch of reasonable conservative treatment,
Yeah.
suppositories, internal pelvic floor therapy, um, and not getting better.
Yeah.
And so I saw the patient, and like, her hip exam was really not impressive. It was
Hmm.
not, like your typical signs of a labral tear with, like, an Arlington test, an internal impingement test. Those are not, they didn't strike me as like a person I would typically operate on. But she'd been having these issues for a couple years, and I said, okay, well, why don't we try a cortisone injection to your hip?
Yep.
Let's see, if we, biochemically calm down your inflammation from your labral tear, let's see what happens. And for like 2 months, her symptoms improved and then went back.
Right.
So, yeah, and then I did a little bit more research, and like there was a small study, I think it was out of New York, where, they were talking about a correlation between pelvic floor and hip labral tears. And, so I said, well, like you got a positive response to the cortisone injection. The only place that went was inside of your hip joint. And the only thing wrong with your hip joint is your labral tear. So let's go ahead and fix it.
Yeah.
And so I did, and her symptoms got better, and she was fine. This- I So after that, I started to do a little bit more. I mean, I'm certainly not seeing patients with pelvic floor dysfunction primarily. I mean,
Right.
I think a lot of people have, uh, pelvic floor dysfunction without having
Oh,
a
totally.
hip
100%.
labral tear.
And
So
vice versa. Yeah.
yeah, so I don't think I'm the right person to see for pelvic floor, but yeah, I think when conservative treatment fails, I mean, I think, looking outside of the pelvic floor to the hip joint,
Yeah.
makes sense. I probably operate on like a dozen patients,
Hmm.
um, female more than male, but
Right.
both with pelvic floor dysfunction, who also have labral tears. A lot of them do have some hip pain, so it's not like solely pelvic floor
Right.
for most of them, but um, a good majority of those patients do get better. Not all of them, but a lot do after when it's appropriate. I always worry about there are people with asymptomatic labral tears, so I see
I
them all the
wanted to
time.
talk about that because that's something that I see come up, and it's such a twist from, like, back I joke around that I had hip surgery before A-Rod and Lady Gaga, so I set the trend, right? But, like, the only reason, like, you were just starting to do them because people weren't scoping hips back
Hmm.
then, and now it's like, now that you can scope, now what do you find? And I find, like, so many women are like, "Oh, I have a labral tear," and back, 15 years ago, we're like, "Okay, that's interesting," but now it's, like, kind of like, "And?" So, I mean, how do you figure out which ones are surgical and which ones are kind of conservative treatment? Because you're a huge proponent for physical therapy.
Yeah. Well, I mean, the short answer is I try physical therapy on everybody,
Thank you.
and then let that, let it sort itself out after that.
Yeah,
I mean, there's some rare exceptions,
yeah,
like a traumatic labral tear.
right,
Maybe a young athlete with a large paralabral cyst from a labral tear, which that their suction seal isn't working. So maybe there's some exceptions, but for the
right.
most part, try physical therapy first. Core gluteal strengthening is a hallmark of non-surgical treatment. See if their symptoms get better with something that's really non-invasive
Yeah,
and self-sustainable, because you can continue your home exercises after you're done with therapy.
yeah.
Um,
For the rehab, knowing kind of that evolution as well, and I have my own thoughts, like, how do you kind of look back on the rehab that we did, say, 15 years ago to compared to the rehab that we're doing now? Like, what's the biggest change that you've seen in and how has that kind of affected outcomes?
Well, I think the biggest change is that just our understanding, both from a physical therapy world and a sports medicine orthopedic surgery world, it has grown leaps and
Oh,
bounds on
yeah.
like what the labrum is not like an appendix, or a useless piece of tissue that you
Right.
can just take out without any consequence.
Yeah.
So we're really working with, like, from a PT standpoint, we're working, really more like going more towards like the posterior chain, as opposed to the front of the hip, and like just
Yeah.
doing a bunch of like straight leg raises to try to strengthen your hip up. We're really working more on that. We're realizing that like hip spine syndrome is
Yes.
huge, and looking at pelvic obliquity and lumbar tilt, and if you can if somebody has like a excessive lumbar lordosis, that's going to change their hip flexion angle to where they impinge. So you can actually, by changing your back, you can actually change how your a position that was symptomatic for you could be asymptomatic, or
Yep.
like no pain, with the same motion, just changing the back. I mean, those,
Yeah.
so from a therapy standpoint, I think that has been the biggest change, is that we're looking outside of the hip,
Yeah.
and looking at everything surrounding the hip and having a better understanding of that.
Yeah, I think so too. The other one I think, as well is just all the research on load and kinda adding resistance training and that kinda stuff has come leaps and bounds as well for I think a lot of different things, tendinopathy as well. It's just like a lot of different areas, and for me, that was my big game changer. I started lifting, I guess it was, 7 or 8 no, it had to be longer, maybe 8 years ago now, um, and that just that was amazing, and the fact that, like, everything still feels good, I'm starting to maybe think about doing another marathon, and the last one I did was before my hip surgery, which is when I had hip pain and that kind of stuff too. So I'm like, all right, lifting heavy weights. I wish we'd had that 15 years ago. That would have
Yeah,
been
no, I
nice.
mean it's like I mean progressive like weightlifting.
Yeah.
I post some stuff on Twitter. I think I posted a couple weeks ago some guy like deadlifting a bunch of weight, like,
Hmm.
8 weeks, 10 weeks out after his hip scope. So
Yeah.
it I'm I'm a fan. I like, weighted squats past 90 degrees. I'm not as big a fan of, because I think that loads your anterior labrum when have had like a labral repair reconstruction. But in general, I'm a big fan.
Yeah. No, me too. For you, like when you see women who are kind of like childbearing years, what are what are the biggest kind of hip complaints that you see, primarily for postpartum women? I mean, I don't know if you remember, like way back in the day, I actually did my DPT capstone project on, I think it was like labral and SI issues or things like that in after delivery in a
Mhm.
pregnant woman or something like that. But like are you seeing anything that's, like, specific to, women who are childbearing age or postpartum or things like that as far as hips go?
Yeah, I mean, I remember you doing that. I think I also did a presentation at Anna like years ago about hip labral tears after delivery.
Mhm.
You know, yeah, I mean, certainly there's a lot of like hormonal
Yes.
changes that
Yeah.
increase flexibility, and like if you're under an epidural analgesia, with delivery. Like I remember one patient of mine swears that she tore labrum when her husband was pushing her knee down, so that he could see the baby come out.
That might
Um,
be a complicated one to kinda tease through there.
yeah. But I mean, I certainly see it a lot after, like, during pregnancy or after delivery,
Yeah.
change in, you load your anterior hip more because of the change in weight. It's going more anterior.
Mhm.
Um, so I mean, labral tears. I mean, at least in my practice, because I'm a specialized sports medicine hip
Right.
arthroscopy practice. I mean, people with like bursitis aren't usually going to come to see me
Right.
unless there's an issue and they're not getting better with somebody else's treatment.
Yeah.
So, so labral tears is the most common, but, hip, there's other things. There's like, hip flexor tendonitis can still happen. It's not all
Right.
labral tears. There can
Yep.
be, hip flexor tendonitis. It does get better with physical therapy and stretching and, and non-surgical treatment. Um, Hip bursitis, I mean, really shouldn't call it that. It's really gluteal tendinosis, or
Right.
degeneration of your gluteal tendons. I mean, that's really common, and it's mainly because, just like our rotator cuffs in our shoulders, we don't really exercise our rotator cuffs per se. There's just part of a stabilizing of your shoulder. Well, your gluteal tendons are similar in that
Yep.
you know you're not really like directly exercising, so that, like, even though the rest of you can be strong, you can still have weak gluteal muscles. And that
Yeah.
it also goes along with low back pain. So low back and hip, they go together like peanut butter and jelly.
Yeah. No, I think especially in like PT world, I think we've really kind of grasped onto, the gluteal tendinopathy and those sorts of things. I'm waiting for the public to stop blaming the piriformis. The poor piriformis, like it's just
Yeah,
been beaten up for years.
yeah.
What about because we are in the most active city in the country, a couple years running now, I think. What about specifically runners? And what are you seeing kind of hip wise typically with female runners? Any difference from, those ones that are coming in 20 something like I did versus, the 30s, 40s, 50-year-old runner? What are you seeing from a hip perspective?
um I mean, certainly with somebody with like subclinical FAI or impingement,
Hmm.
their symptoms are going to be gradual in onset. And a lot of times those symptoms will be a combination of their labral tear, and then because of the labral tear, starting to get early arthritis in their hip. So,
Yeah.
somebody who's, a runner in their 50s and they come to see me, and if they have impingement on x-ray, they probably also have a little bit of arthritis because
Hmm.
like they had that impingement since they were skeletal mature at age like 14 or
Right.
15. So you're talking about 3.5 decades of using their hip. Their labrum probably tore like a decade ago, or like
Right.
like kind of degeneratively torn, and then it's not protecting the gliding cartilage. So like some mild arthritis and labral tears, that you see that, and that'd be a whole other podcast on what do you do
Right.
with that. Um, but that's relatively common in runners because unlike ballet dancers or figure skaters or gymnasts where they're putting their hip through a hyperphysiologic load. I mean, a lot of people can't put their hip in a position that a ballet dancer
Right.
can routinely puts their hip in. So usually those people beat up their labrum and tear it really quickly and noticeably, and they're symptomatic really early on.
Hmm.
So in some ways that's good because you can get to the hip before the cartilage starts to degenerate. So before
Mm.
they start getting any arthritis, you can address
Right.
the hip. Now the downside is they're going to go back to being a ballet dancer, which is
Right.
a is the that's the most hip intensive sport that I
Right.
treat is ballet.
Yep.
Um, but you can cure them and you can get to them before the cartilage damage occurs. So those explosive high mobility hip athletes, you a lot of times you get symptomatic labral tears without having any articular cartilage damage at all.
Yeah.
When it's more distance loading, like repetitive,
Yep.
those are not as symptomatic when they tear their labrums. So then they just continue to keep going because it's
Yep.
really not that bad for them. And then their cartilage starts to degenerate as their labrum continues to
Yeah.
degenerate as well.
Yeah, it's interesting. I was never a dancer, never could get my hip there anyway, so that's why. But that's actually one of the questions that I ask new clients when they come in is if they danced as a kid.
Mhm.
Um, is it kind of gives us a sense of how they moved, for a long time. And actually, a lot of those patients end up with and my theory is it's some sort of stability mechanism later on in life because they're not as active or working through those ranges of motion, but end up with more high tone pelvic floor because they're looking for some stability mechanism. I don't know whether that's actually true or not, but
Mhm.
typically that's one of the things that we'll try and kind of address and down train. And typically they will have some, past history with a hip issue or something like that. But that's where I think kind of understanding those sports, it can be incredibly helpful understanding biologically what somebody kind of gravitated to movement wise as a kid. If they're not doing it anymore as an adult, what issues can kind of sort of stem from that. But yeah,
That's extremely interesting.
yeah,
Like I'm like very interested in that. The other thing is that people who like tend to dance through high school and
yeah,
college tend to be like the best dancers in their class because they were good at it. So they tend to be hypermobile. They may
hmm,
trend to be more likely to have, like a clinical hypermobility syndrome like Ehlers-Danlos
right,
syndrome.
yep.
So, I'm sure that plays a role as well,
Well,
too, in
and
what you're seeing.
I think with ballet too is, and any of those aesthetic sports, I mean, I think skating or gymnastics could be in there too, if it's the aesthetics that they were taught. And I mean, now me understanding, having had a daughter myself and what she's being taught movement wise, if you're being taught as a 3-year-old that you've got to hold yourself and that's what you learn from a movement strategy perspective, that's going to carry through for a really long time. Not to
Yeah.
mention you live here in the DC metro area. And so everybody here is a little, we're wired a little bit tight. Um, I feel like there's definitely those things that we walk, that we carry through from when we were kids. And when you're learning these movement strategies at such a small age, it can't help but be a bias. So
Yeah.
I'd be curious someday. Somebody needs to do that paper because I'm not going to. But
Yeah. No, I mean, I'm really interested. Well, like maybe you and I can get together because
yeah,
I always thought that, I wanted to make a new school of ballet
Mm-hmm.
where 45 degrees of turnout is optimal. Like
Oh, wow.
that's the most aesthetically pleasing is that.
Okay.
And
It's a whole
then
new culture then. That's a whole new cut. The little that I know about dance, I work for a practice that we both know for a number of years, very focused on dance, and it was just eye opening to me. And it's funny when my daughter was 3. There's a dance studio across the street that's now closed, and I took her in. First day was great. They had a sub. The second day, the woman wouldn't let her participate. Like she sat out because she was a little nervous, but she wouldn't let her wear the tutu for the last part because she didn't participate in the whole thing. And I'm like, I'm out. I can't handle this because I'm not
yeah,
going to screw up her body and I'm not going to,
right,
girl's going to have the tutu. So
yeah,
we'll pull Sky Donovan in and she can do the IRB for us.
yeah.
Okay.
Sounds good.
Add that to the list. All right. So when do you, as a hip surgeon, when are you like, hey, maybe you should kind of talk to somebody who is a pelvic floor PT, or is that something that usually you think comes more from a rehab kind of referral?
I mean, they usually come in already having seen pelvic floor
Yeah.
therapists.
I think it's so much better than it used to be
Yeah,
too.
I mean, I think the awareness from OBGYNs and
Yep.
family practice physicians is a lot higher with that
Yep.
than it was 20 years ago, and
Yes.
so now if somebody came in and they had like erectile dysfunction, vulvodynia, diffuse kind of cramping, perineal numbness. I mean, those kind of things where there's no
It's blatant.
like
Yeah.
then I would say like, look, I mean, I think you should see somebody like yourself or
Yep.
a pelvic floor therapist. Ideally somebody can also do physical therapy along with pelvic floor, but
Right.
otherwise, like, break it up and do both. Because I think they
Yeah.
can both work hand in hand.
Well, and I
Um,
think now there's more. I feel like there's people that just go into orthopedics or just go into pelvic floor. I don't think there's as many of us that kind of straddle both lines. But it's fun though. It's
yeah.
fun. It's fun when you get to play with pelvic floors and then also have them play with the barbell in the other room and that kind of stuff too. So okay, last question for you because I know you got a jet. If you are a woman and you have hip pain and you Google FAI or you Google labral tear and you're like, oh, I should go to see somebody. How can we vet a good hip doctor?
um, that's a hard question.
Come
Yeah,
see you in Arlington.
yeah. I mean, I would. All right. So if you're like 75 years old and somebody told you had arthritis, I mean, you don't need to see somebody like me.
Hmm.
You need to see a general orthopedic surgeon and, talk about hip replacement, which is a phenomenally successful operation. But if, you're a young patient, no hip arthritis, um, I would, uh, probably like look, like try to get some names from the area, but try to look them up, see if they're members of ISHA, which is the International Hip Preservation Society. So if they're a member, then at least you know that they're thinking about
Yep.
always trying to get better and improve our outcomes. If they're a member of AANA, AANA, it's the Arthroscopy Association North America. I mean, I think that would be really good. I mean, you can Google them specifically if they've got tons of articles on hip arthroscopy, if they have a Twitter site, and then they have a bunch of like hip scope patient pictures and things like that. I mean, you can get a sense from that too. But
Yeah.
I mean, like, the best thing to do though, like the best thing would be whatever area you're in, talk to the physical therapists,
Yes.
okay? And then ask them, have you ever seen this doctor's patients
Hmm.
in rehab after hip arthroscopy and how have they done? And would they recommend that doctor? And I think
Yeah.
that's an excellent way of doing it as well.
That's awesome. I do the same thing when I have patients that are moving to another state is I'll find them the PT that I know and I like, and I'm like, "Go talk to them first and then figure out who they like." So, yeah, no, we know the best ones, right?
Right, right.
Awesome. All right. If you want to know more about Dr. Ochiai, you can find him on Twitter or whatever they're calling it this week. He's a hip nerd, and also occasionally we'll throw some ninja stuff up there because of your martial arts background. So you can find him on Twitter there. And thanks so much for sneaking us in between surgeries and all that good stuff. And it's good to
this
chat.
was so much fun talking to you. Thank you
Thanks
so
so
much for
much.
having me on, Carrie.
Thanks. Did you enjoy the podcast? If so, leave us a 5-star review on iTunes and tell a friend to do the same. Are you a postpartum mom or postpartum pro wanting to know more about getting back to running after baby? Check out all my free goodies on carriepagliano.com. This podcast represents the opinions of Dr. Carrie Pagliano and her guests to the show. The content should not be taken as medical advice and is for entertainment purposes only. Always consult your healthcare professional for any medical questions.